Myself, Dr. Maulik Sanghvi, working as a general medicine physician at Vashna, Ahmedabad, Gujarat. Today, our topic is around latest update in hypertension. What is latest update in hypertension? In introduction, as per the WHO, nearly 63% of total deaths in India are due to non-communicable disease. Out of 63 total deaths, among 27 are because of cardiovascular disease, and out of that, 45% of the people between the 40 to 69 age group. So, rise blood pressure is among the most important risk factor for cardiovascular disease. Moreover, it remains poorly controlled due to low of awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. So, what we can do, we can advance. We have to improve the awareness about hypertension and proper follow-up. So, in India, prevalence has also gone over the year of 30 years from 38% in men and 32% in women, from 29% and 28% in past, respectively. Despite that, nearly half of the people, means out of 51% of the men and 41% of the women with hypertension, is unaware of his hypertension condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer in out of five. There is a one man and one in into four women with hypertension worldwide, as per the Lancet guidelines WHO 2021. So, International Society of Hypertension has released the ISS 2020 Global Hypertension Practice Guidelines. These guidelines include optimal and essential treatment paradigm attempts to address the issue that in resource poor setting. Optimal care refers to evidence-based standard of care, and wherever essential standard refers to minimum standard of care to allow specification of essential standards of care of low resource settings. The AHA, American Heart Association, and American College of Cardiology has released a scientific statement in 2021 offering a new guidelines for management of stage 1 hypertension. Stage 1 hypertension among low risk adults, those who have a AS CVD risk 0 or less than 10 years, CVD risk is less than 10%. In blood pressure between 130 to 140 systolic or 80 to 90 diastolic millimeter of mercury. Management start with non-pharmacological therapy, including diet, exercise, and the lifestyle modifications. If out after 3 to 6 months of this non-pharmacological therapy, blood pressure remains uncontrolled, then we have to think about pharmacological therapy as per the 2021 hypertension guidelines. Now, acute respiratory distress syndrome (ARDS) is a potentially fatal condition. It is a pulmonary edema because of rise blood pressure. Uncontrolled hypertension is a hypertensive emergency that involve the breathing problem and severe lung damage. A recent study which appears in the Journal of the American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS, as per the 2021 JM call Cardiol guidelines. Lowering systolic blood pressure targets down to the 110 to less than 130 millimeter mercury rate substantially reduce the severe adverse event. The STEP randomized trial affirming the sprint finding for an older Chinese population. Among some 8,500 patients aged between age 60 to 80 in China, the intensive target trimmed 26% of the composite CVDs, finding from now a second major trial reporting a lower target could unite the guidelines, which even among US professional society range from threshold of 130 to 150 millimeter of mercury. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only depend on the office BP measurement, but also on out of office measurement, including ABPM at ambulatory blood pressure monitoring or home blood pressure monitoring. 24-hour and nighttime BP measurement were associated with greater risk of mortality and a composite of CV outcome. Thus, they may be considered as the most relevant measurement for estimating CV risk. For every 20 systolic and 10 diastolic millimeter mercury increment of BP measured at night, the risk of mortality increased by 23% and risk of cardiovascular events by 36%. So, most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend 5 classes of anti-hypertensive drugs, considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the contents of the lower BP targets, to start antihypertensive therapy with an initial dual fixed base combination ACARB with CCB or diabetic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of the known carcinogen NDMA, which can be found in cambisartan, albisartan, losartan, and olmesartan and valsartan. So NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. In 1 lakh patients would have received NDMA contaminated valsartan from the Jianghuai manufacturing site every day for 6 years in the highest dose. It could result in a 22 additional liver cancer over the lifetime of this patient. The presence of NDMA in this drug could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. While certain recall accompanied by a significant increase in the rate of emergency department visit of 6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints like death. The HYGEA chronotherapy trial tested whether nighttime therapy is in comparison to usual upon awakening hypertension therapy exert a favorable risk reduction. The largest study included a total of 19,084 hypertensive patients. In this study, during an average follow-up of 6.3 years, the 1,752 participants experienced the primary CV outcome. Ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR reduction for CV agent was significantly improved for nighttime treatment when compared with awakening treatment. So in this all studies, we are conclude that we have to what the importance of blood pressure in the CV outcome, and we have to measure the blood pressure, and we have to advance the therapy, including non-pharmacological and pharmacological therapy, and a proper follow-up. That is the message of today's our update discussion. Thank you.